Hello, everybody. I'm Abe Morgentaler. I'm an associate professor of urology at Beth Israel Deaconess Medical Center and Harvard Medical School in Boston, Massachusetts. And I'm delighted to have this opportunity to present our latest research done together with my collaborators, Alejandro Abello and Glenn Bubley, also from the same institution. This article was published in July in the online journal Androgens and is entitled Testosterone Therapy in Men with Biochemical Recurrence and Metastatic Prostate Cancer Initial Observations. The background to this is that all doctors have been trained really for many decades that raising testosterone in a man with prostate cancer is like pouring gasoline on a fire or feeding a hungry tumor. We all learned that terminology, those phrases. I taught them myself to my residents when I came out of my training. And for that reason, testosterone therapy has been considered contraindicated in men with any history of prostate cancer traditionally, or even suspicion of prostate cancer. And if you look at least in the United States, any product label for testosterone, it has that very warning on it. Yet, for approximately 20 years or so, there's been a growing body of evidence that suggests that testosterone therapy appears to be safe, at least in certain groups of men, including men with prostatic intraepithelial neoplasia after radical prostatectomy, after radiation therapy, all of these, of course, for prostate cancer, and limited data, but several reports that it doesn't even seem to cause progression in men on active surveillance, at least not compared to men who did not receive testosterone. But the big concern, of course, has been what about men with metastatic disease or advanced prostate cancer? And I want to share with you here our initial results in a series of these men. So this was an observational study that was comprised of 22 men, all symptomatic from low levels of testosterone, and who sought me out, many from out of state, for the specific reason that despite their advanced prostate cancer, they wanted to be treated with testosterone therapy. Of these 22, 7 had biochemical recurrence, 13 had frank metastases, either nodal disease or bone metastases. 2 of them were high risk who were placed on androgen deprivation therapy following treatment with CyberKnife. The median age of the overall group was 70.5 years, and the median duration of testosterone therapy was 12 months, with a range of 2 to 84 months. All of these men reported symptomatic benefit from testosterone. In many of these men, really quite remarkable symptomatic benefit. I've dropped out in this figure the 2 men who were on adjuvant ADT. One of them stopped within a couple of months because he was told by his doctor it was by another doctor it was dangerous. And the other man continues to this day, but is on testosterone together with enzalutamide, whereas he'd initially been on enzalutamide with Lupron. In any case, the bigger groups are shown here: biochemical recurrence 7, metastatic disease 14. One of the men with biochemical recurrence went on to develop metastatic disease, and his data are included for those respective time periods in both he's in both columns. Median age for the biochemical group, recurrence group, was 69.5 years, 72 in the metastatic group. Median PSA was 3.1 for the BCR group and 4.1 on metastatic disease. If you go down to bone metastases, the biochemical recurrence has no bone mets, no nodal mets. And you see here for the metastatic group that 71% had bone mets and 50% had nodal mets. Half the men in the metastatic group had already been on androgen deprivation. And then you see at the last grouping, we have something called MBAT, which is a modified bipolar androgen therapy, which is something that I had published on previously. Many of you may be familiar with the remarkable work of Sam Denmead at Hopkins and his co-investigators, who introduced the concept of bipolar androgen therapy. And what they did is they give their reports have been exclusively, I believe, in men with castrate-resistant prostate cancer. And what they've done is cycle every 4 weeks a high-dose injection of testosterone in men who are also on an LHRH agonist. And so when the injection or the testosterone wears off, if you will, they go from exceedingly high levels down into the castrate range. And then at 4 weeks, they get another injection of testosterone and they go up again supraphysiologically, and that's the bipolar part. I started a modified protocol really at the request of one of my patients that's in this series, because he wanted to be on testosterone for a longer period of time, but wanted to try and take advantage of the bipolar concept. And so modified MBAT or MBAT is 8 weeks of high dose testosterone, followed by 4 weeks of an androgen blocker or anti-androgen, most commonly enzalutamide. And then they go back on 8 weeks of testosterone again. And you can see that 57% of these men were treated in that fashion. That's their form of testosterone therapy. The others were just on straight testosterone. And here's some of the baseline and follow-up variables. If you look at median baseline PSA in the BCR group, it went from 3.1 to 13.3. That's with 20 months median testosterone therapy. Metastatic group were on a shorter period of time, 9.5 months, and their PSAs went from 6.3 to 17.8. You look at the change in PSA. Actually, I think this is the same data just shown graphically. This is biochemical recurrence, and this is the metastatic group. Mortality, there were no deaths in the BCR group, but all the mortality happened in the metastatic group. Overall mortality was 13.6%. The PCA-specific mortality was just one patient, 4.5%. And that's during the time of testosterone therapy or in the 6 months following. There were 2 additional deaths. One man who'd been on testosterone for 7 years despite metastatic disease died not from prostate cancer, but from myelofibrosis. And then one gentleman had complications after myocardial infarction. Morbidity, we saw 3 men who had increased bone pain at between 7 and 41 months. One man who died had a MI at 10 months, but he was a vasculopath with a prior history of 3 strokes. One man, the gentleman who'd had biochemical recurrence and went on to metastatic disease, ended up having bone marrow replacement with tumor, subsequently, which is when he stopped his testosterone and went on androgen deprivation. One man developed urinary retention and urosepsis. One man developed a DVT. But most interesting is what we didn't see, because we've been so afraid of any rise in testosterone that we're still worried about testosterone flare in men, which is why we often give an anti-androgen together with an LHRH agonist. And testosterone flare, the rise in testosterone, is back to baseline by 7 to 14 days. My training was that if you didn't block it, people could get pulmonary emboli, spinal cord compression, sudden death, fractures, and we saw none of this. over, in some cases, very extensive periods of time. Nor did we see any rapid or precipitous progression of disease in any individual. In the metastatic group of 10 men who had imaging within 12 months, 7 of them showed no progression of their disease. It was stable. And just to give you a flavor of what this really is all about, one of the very first patients I saw was a 94-year-old scientist. He had a history of Gleason 9 cancer. He had diffuse bone metastases. He had extensive nodal disease, which necessitated him to have bilateral nephrostomy tubes placed. His PSA when I saw him was the highest I had personally ever seen up to that time, at greater than 500. He'd been treated previously with androgen deprivation and he hated it. He was still sharp at 94 when he came to see me, but he discontinued androgen deprivation at 6 months. He was just too weak to walk. And he considered himself a very active, or wanted to still be a very active person. And he came in from out of state specifically asking me to treat him with testosterone. And when I asked him, why do you want to be on testosterone? He said, well, you know, I used to work out daily and I can't anymore. I'm too tired. It used to make me feel good. And I have colleagues all over the world, and I used to correspond with him. He had something like 100 patents. And he says, I'm just too tired. I don't have the motivation, and I'm just tired. I want to be able to do that. And I told him, you know, you could die from this. It could be days, it could be weeks, it could be months, but it could happen suddenly and quickly. And he said to me, Doctor, I'm 94 years old. I'm going to go sometime. I know I have metastatic disease. And while I'm alive, I want to live as well as I can. He saw me with his daughter, who was a nurse practitioner, and together they were willing to sign whatever it was that, that I wanted them to sign in the way of informed consent. They were from out of state, and the daughter was the one who ended up giving him his treatment with testosterone injections every 2 weeks. She sent me this picture of him with his approval, and I show this with his written permission at the time. Sitting in the waiting room of his dentist's office at 7 months after beginning testosterone therapy. At that time, he was 95 years old, and I would suggest to you that he looks pretty darn good. His treatment was to get 400 milligrams of testosterone cypionate every 2 weeks intramuscularly, which is a high dose, and the high dose comes about from some work done by Mokira and others, showing that high-dose testosterone actually appears, at least in vitro and in animal studies, to be suppressive, to inhibit prostate cancer growth. Within 6 weeks of beginning testosterone, he noted that his brain seemed clearer. He was working on his next patent already. He was exercising daily or close to daily. His appetite improved. He gained some weight. He'd been very thin. At no time did he experience bone pain. He died at 11 months. His PSA was greater than 2,000, but I think that he was absolutely delighted with his treatment until the end, of course, and really encouraged me to tell his story, which I'm doing today. My work with him when he was 94 is what prompted me to consider doing this in men who were younger. This is another patient who, and I'm showing here the curve for somebody who was on modified bipolar androgen therapy. You can see here from the dates, this is April 2017 to April 2019, 2 years, that what happened, blue is PSA, and in the orange or red, whatever it shows up on your screen, is testosterone levels. So they go on 8 weeks of high dose testosterone and then 4 weeks of a blocker, in this case, enzalutamide. And then those cycles get repeated and PSA goes up and down. This gentleman did very well for 2 years. At the end of 2 years, he noticed it had some hip metastases and noticed that he was getting a little bit more discomfort, not awful, but a little bit more discomfort during the periods of time he was on testosterone. His PSA, even at the naders, were climbing, and he elected to discontinue and went on standard ADT. So what does all this mean? You know, this is a relatively small series, but this is the first series of a group of men in this situation. You know, one of the conclusions is there clearly are men who prioritize quality of life over duration. And that was true for all of these men. All of them were told that this was completely non-standard treatment, that the belief, and I believed it might be possible myself, that they could die extremely soon after we initiated testosterone therapy. That's been the training. But they were willing to do that. Androgen deprivation therapy has been shown to have, you know, any number of benefits, but one thing it doesn't benefit is quality of life. And there are some people for whom that is much more important than living a longer life. I believe these data once again contradict the belief that testosterone therapy in men is like pouring gasoline on a fire. I just don't see the evidence from it in any of the situations now in which we thought that that would happen. And certainly for men with biochemical recurrence, again, small group, but it's unclear to me what would be the basis for denying testosterone therapy to those men. They do not yet have metastatic disease. Some of those men may not develop metastatic disease or may even die before they get it, depending on their age and their medical status. And I think that it's reasonable given these data. I think that at this point, testosterone therapy may be a reasonable option for selected men with metastatic prostate cancer who refuse androgen deprivation and are willing to accept the risk that their cancer may progress more rapidly. Although I would suggest to you that the data that we've seen so far do not support that idea, that it's some kind of death sentence for these men in a short period of time. So it's been a remarkable experience for me. I've learned so much about not just testosterone and prostate cancer, but also about, if I may, sort of the spirit of men, some of whom are totally inspiring, you know, faced, I suppose, if I can get philosophical for a moment, you know, we're all going to die at some point. But men who have been diagnosed with metastatic cancer are faced with that in a much more acute way than most of the rest of us. And this concept of being willing to accept the risk of a shorter life in exchange for the ability to live one that may be more satisfying to them, to go out on top, as one of these guys said, is really impressive and inspiring. Thank you all very much for listening.